Okay, thank you, Arvind Kumar. Thank you for confirmation. So here we go. Now, the very first question is it was about it was based on the concept of referred pain actually, and it was asked like if there is acute tonsillitis, and based on that entity, if there is referred ear pain, which nerve is involved? So I think most of you must be knowing what actually the concept of referred pain is. So when we talk about referred pain, it in simpler word, it means that there are two structures, suppose A and B, right? And of course, if there is any pain sensation, it will be carried to the brain from both the structures, right? Now the concept is that the nerve which is carrying the pain sensation from both the structure is same. Okay, so therefore what happens, suppose if there is pathology in A and the pain sensation is going through the nerve, the brain will perceive as if there is pathology in B, and that is what being told to us by the patient. So that is the concept of referred pain, and that is because the two structures, they have the same nerve supply, and therefore the brain gets confused that what is the actual source from where the pain sensations are coming, and it mistakes the other structure as the source of those pain sensations, and hence the patient, when comes to us in the clinic, he will say that I am having pain at site B, but in reality he was having pain at site A, or there was some pathology at the site A, which is the reason for this pain, right? So that is the concept of referred pain. Now coming back to the question, now here the patient is having acute tonsillitis, right? So it means there is origin of pain which is because of that inflammatory process in the tonsil, and from here it is actually the ninth nerve which takes away the sensations of pain, right? And ninth nerve is also one nerve which is carrying pain sensations from the middle ear. So if you know the nerve supply of the middle ear, it is provided by the glossopharyngeal nerve, right? So what happens, the pathology is in the tonsil, but the pain is felt by the patient in the middle ear, and that is known as the referred pain, because there is no pathology as such in the middle ear. It is just because the pathology is somewhere else, but since both the structures are having common nerve supply, therefore the patient might come to you with ear pain, or what we call it otalgia, right? So if a patient comes to you with ear pain, it does not mean that he is going to have ear pathology only. There is possibility that the pathology is somewhere else, and the patient is coming to you with ear pain. So that is very important concept as far as this ENT practice is concerned, because if you are focusing yourself only on the ear, you will never reach up to the exact diagnosis, right? And now in this question, it is only about the glossopharyngeal nerve. Now there are many other nerves which provide sensory innervation around the area of the ear and also to the ear, and therefore there might be the overlap, and we must know that this referred pain might come into play. So the concept of referred pain might come into play, and therefore you should know the nerves which can lead to the concept of referred pain. So the very first I have already explained to you, this is cranial nerve 9th, right? So first is cranial nerve 9th, and cranial nerve 9, it can, it supplies tonsil or even parotid gland, right? So these are area from where there can be referred pain to the ear. Now the second nerve which can lead to this concept of referred pain is the 7th nerve, right? And there is one condition that is known as stylalgia, that is Eagle's syndrome. So there is elongated styloid process. So this can also result in the concept or the possibility of the referred pain, right? Then third, if you see auriculotemporal nerve, which is originating from the mandibular division of the fifth nerve, then there are the auricular branch of vagus nerve is one more. So you can just add 10th nerve also, and you can add the 5th nerve also. So these are all cranial nerves which can lead to this beautiful concept of referred pain to the ear. So one should know that if a patient is coming with ear pain, it is not necessarily that the pathology is within the ear. It can be in the surrounding area, and since the ear is also getting some nerve supply through those nerves, so that concept of referred pain actually comes into play here, right? So this is in short about the nerve supply of the external ear, auriculotemporal, then greater auricular branch of vagus, then greater auricular nerve, and the lesser occipital nerve and facial nerve also, right? So these are few nerves which can give rise to otalgia or the referred pain in the ear. Okay, so again this is the perfect figure. So if we take the example of say seventh nerve is not shown in this. Okay, so if I skip, so ninth, if we take the example of ninth nerve, then you see it is supplying the posterior 1/3 of the tongue. I think all of you must be knowing it. So posterior 1/3 tongue, then this is all tonsil, right? So these are area which can cause referred pain to the ear through the involvement of ninth nerve. Then larynx and maybe laryngeal vagus nerve. Then the fifth nerve, it can be the anterior 2/3 of tongue, temporomandibular joint, then teeth, of course. So this is all for fifth nerve, right? And then 10th nerve can also, like if there is GERD, especially this is GERD, right? So this is all GERD. And then fifth nerve, there can be involvement of nose or sinus, and this will cause referred pain through the fifth nerve. And of course for seventh nerve, it can be because of Eagle's syndrome, that is elongated styloid process, right? So what I mean to say actually is that there are many nerves which can lead to referred pain because they are supplying some other structures and also the ear, and just because of that concept of same nerve supply, there is the concept of referred nerve here, right? So in this particular case, the question was about acute tonsillitis. So it is because of the involvement of glossopharyngeal nerve, right? So this is the beautiful concept of referred pain. So in acute tonsillitis, referred pain, the answer has to be glossopharyngeal nerve. Okay, chalo, moving to next question. And again this is about high tracheostomy. High tracheostomy. See, there is only one indication when we do high tracheostomy. Any idea? So what is that single indication? There is only one indication in which we go for high tracheostomy. Otherwise we don't prefer doing high tracheostomy. Any idea? Anyone? What is the indication for high tracheostomy? And in simpler words, if you say it is through first tracheal ring, okay, and this tracheal ring is above the isthmus of thyroid gland. Very good, Arvind. You are right. So it is laryngeal malignancy. Yes, you are right. Right. So it is, the only indication is laryngeal carcinoma. Right. So it is done through the first tracheal ring. Fine. And above the level of isthmus of thyroid gland. So suppose this is thyroid cartilage. Okay. Let me. So if this is thyroid cartilage here, something like this. Below thyroid we have the cricoid, right? So this is cricoid cartilage here. Okay. So this is cricoid. This is thyroid, right? And then below cricoid there is the tracheal rings. So suppose this is the first tracheal ring. Clear? And then this is the isthmus of thyroid gland, right? So thyroid gland will be something like this. Okay. So this is the isthmus of thyroid gland, and this overlies nearly second to fourth tracheal ring. Clear? So what we are doing in emergency tracheostomy, we are making a opening here in the first tracheal ring, and then we are putting the tracheal tube. Right? Now, in usual circumstances or other conditions, we don't go for high tracheostomy because so this is the level of high tracheostomy. We don't go for it because it can lead to perichondritis of the cricoid cartilage, and there may be stenosis kind of complications. So usually we don't go, but only if there is laryngeal carcinoma we can go for high tracheostomy, right? So please remember, for high tracheostomy there is only one indication, stridor, which is because of laryngeal carcinoma. And I think most of you must be knowing what stridor is. Stridor are the sounds which are produced because of the movement of air, right? So this is the high tracheostomy. And if I just show you through the images, and this one is thyroid cartilage. Okay, so this one is the thyroid cartilage, this one is the cricoid cartilage. Then lower down if you go, this is first, then second, third, fourth, fifth, sixth. These are all tracheal rings. Okay, so this numbering is actually tracheal rings. This lobe is of course the thyroid gland. Okay, this is thyroid cartilage, right? So don't mix. So when we are saying that we are going for high tracheostomy, it is actually this area where we'll be making a opening, so through the first tracheal ring. Okay, so this is high tracheostomy. Again, if I show you here, this is the area of doing high tracheostomy. Okay, right? So this is high tracheostomy. So, and you can see this is the isthmus. So this all is the isthmus of thyroid gland, and the level of tracheostomy is just above the isthmus. So this is the high tracheostomy through the first tracheal ring above the level of isthmus. Okay, and we usually don't prefer it doing because it can cause perichondritis of the cricoid cartilage, which can lead to subglottic stenosis. So usually it is not preferred, and there is only one indication, that is carcinoma larynx, when we have already decided that we will go for total laryngectomy, right? So this is the concept of high tracheostomy through the first tracheal cartilage just above the isthmus of the thyroid, indicated in carcinoma of larynx, which has been planned already for total laryngectomy. Clear? After that we can go lower downward, and we'll make another tracheostomy, right? So this is high tracheostomy. Chalo. Next question was about an implant placement. So that is auditory brainstem implant placement. So this is about brainstem implant. Now what is the location of the placement of this auditory brainstem implant? So especially the electrodes, it's actually about the electrodes, where these electrodes are kept. Now here, this is especially done if there is agenesis of 8th nerve. So the auditory brainstem implanting, it is especially done if there is the damage or missing 8th nerve, right? So this is especially done in those cases. And if we look at the assembly of this implant, there is a carrier. So there is a carrier, okay, and it has somewhat about small disc electrodes, right? So nearly it may be around 20. So you can have these disc electrodes, and these are kept near to the cochlear nucleus, right? So this is kept near to the cochlear nucleus, and the usual site of placement is through the lateral recess of the fourth ventricle. So this is the lateral recess here. So I think if you can see, this is the fourth ventricle, a diamond shaped space, okay. So this is the fourth ventricle, okay. So this is the fourth ventricle, and if you know that from the fourth ventricle, the CSF leaks out into the subarachnoid space through a central foramen of Megendie and two lateral foramens of Lashka. So those are actually the lateral recesses, okay. So these are the lateral recesses here, right? So these are the lateral recesses, and we use these lateral recesses for the implantment of the electrode. So the electrode is implanted somewhere here, depending on the site of in which the implantation is needed, right? So this is the lateral recess, and here we keep the electrode carrier, right? So with those discs. So this is how we are doing this auditory brainstem implant placement. And whenever we say brainstem, I think most of you must be knowing what the structures are there in the brainstem. So we have three structures: the midbrain, pons, and medulla. And now here we just discussed that this is the fourth ventricle here. So this is all fourth ventricle, and now from anatomy wise, the floor of the fourth ventricle actually forms the floor. So pons is related to, in simpler terms, pons is related to the fourth ventricle, right? So it is related to fourth ventricle. So anteriorly there is, if you say this is the pons, something like this, which continues as medulla, and posteriorly you will see this is the fourth ventricle, okay. So this all is the fourth ventricle, clear? And anteriorly this is all pons, lower is all medulla, clear? So the fourth ventricle is actually forms the floor of the pons anatomy wise. Anyway, so I think the placement of this auditory brainstem implant might be clear to all of you. So this is all pons, okay. So this is all pons anteriorly, clear? And we use the lateral recesses related to the fourth ventricle for the placement of the electrodes which are in close proximity to the cochlear nuclei. Fine. So this is in short about this placement of the implant electrodes. And in NEET-PG you have these kind of questions like about some implant or some other supportive method for hearing. So this is about brainstem implant placement. Now this is a very common topic, the blowout fracture of orbit, and I think most of you can answer it. It has been repeated many number of times. So most commonly fractured area in blowout fractures of orbit. So any idea which area? So suppose if this is the nasal opening, these are the orbits. Okay, so the commonly fractured area is either the floor or the medial wall, right? So it is either the medial wall or the floor. So this is the medial wall of orbit and this is the floor of orbit. Okay, so usually it is the floor of the orbit which is which just breaks out whenever there is a blowout fracture of orbit. And you must have heard of those blunt injuries, maybe by fist or some ball, which might lead to this blowout fractures. And here, so the commoner one is the orbital floor and the second common is the medial wall, right? And then there are two terms related to the blowout fractures, and these are actually the fractures of orbit. One is the impure fracture and another is the pure fracture, right? So there are two terms, pure fracture and impure fracture. Now if the fracture, now this is all orbital rim. Okay, now if the fracture line extends and involves the rim, this becomes a impure fracture. Okay, so in impure fracture the fracture line involves the orbital rims, or you can say the margins, and if the fracture is limiting within the orbit only, not extending up to the rim of the orbit, then this is known as the pure fracture, right? So pure fracture, impure fracture, this is one classification. And if I show you the image and a CT scan, you can see that this is a normal side. Okay, you can see the integrity of the orbital floor, but on this side you can see that the integrity is broken. So this is blowout fracture, right? So here you can see there is fracture of the floor of orbit, right? So this is how it is seen on a coronal CT scan. So this is a coronal CT scan. Fine. And again you can see there are telltale signs of blunt injury to the eye. So that is all blowout fracture, right? So just remember floor of orbit. Now while discussing the indication of high tracheostomy, we discussed about that stridor of laryngeal malignancy is a common indication for high tracheostomy. So the question is about inspiratory stridor, because stridor, it can be inspiratory, okay, it can be expiratory, and it can be biphasic. Biphasic means both inspiratory plus expiratory, right? So the stridor, which is the sound because of movement of air through the respiratory tract because of some partial compression from outside, that results in stridor. So it can be inspiratory when the person is inhaling, it can be expiratory when the person is exhaling, and it can be in both the phases. Whenever the person is inhaling or exhaling, the sound is coming. So that is biphasic. Now this depends on the anatomy of the respiratory passage, right? Whenever the word is inspiratory, this is usually related to the vocal, the area of the vocal cord. So it is supraglottis, right? So supra is above, glottis is of course the vocal cords. Clear? So this, if there is any obstruction, if there is any compression in this particular area, and when the patient will breathe in, it will produce sound, that is inspiratory stridor, right? So supraglottis or pharyngeal, that is inspiratory stridor. If you go down, it will be biphasic. So biphasic, as I told you, it is in both the phases of respiration, that is inspiration as well as expiration, and this will be seen in vocal cords, below vocal cords, and only cervical portion of trachea. Okay, because if there is any pathology beyond this, especially involving the thoracic trachea and the bronchi, that will give expiratory stridor. So the kind of the kind of stridor, it actually depends on the anatomical location of that pathology, right? So inspiratory stridor, that is supraglottic in location. Clear? So if someone asks you what is the reason or what is the region of pathology in inspiratory stridor, you will say it is supraglottic. Clear? Just above the level of vocal cords. And this is glottic as well as subglottic. Clear? And cervical trachea, and here this is all thoracic trachea, and when it divides into two bronchi, that area as well, right? So this is how we classify the stridor. So just remember this much. Now next question: a young male presented with painless watery discharge from the ear, and the otoscopic picture is given. Any idea what is this? If you look at the otoscopic image of the tympanic membrane, you can see this is one perforation here, this is second perforation here, and this is the third perforation here. So you can easily see that there are three perforations in the tympanic membrane. So your otoscopic impression is that there are multiple perforations. Clear? So you can say that there are multiple perforations. Now here the discharge is painless. This is very important clue. So the moment you have this kind of picture, the answer has to be, yes, anyone? What can be the answer here? Yes, anyone? Two important clues. I'll just summarize. Painless, watery discharge, and multiple perforations. Now these two are enough to make a clinical diagnosis of tubercular otitis media, right? So this is infection of the middle ear because of tubercle bacilli. Although very rare, but the presentation is classical. The moment you see three perforations, go for tubercular otitis media. Clear? And this is one question which has been repeated in FMG also, so it's very important here. And so the classical thing is multiple tympanic membrane perforations. Please remember this. And then there is one more important point here, pale granulation tissue, right? So this is also important clue. So pale granulation tissue, and then we can demonstrate AFV and all, that's different thing. So presentation wise, multiple tympanic membrane perforation and pale granulation, that is also important here. And of course clinically the discharge is painless, and you can say watery discharge. So a very classical presentation for tubercular otitis media. Now what is this condition here? Any idea what is this condition which is shown in the image? Yes, anyone? Now this is known as Keratosis obturans, right? So this is Keratosis obturans, and you can see it has almost filled the entire external auditory canal. So this is Keratosis obturans, and when we remove it, you can see it has almost the same the shape of the external auditory canal, right? So, and the name is Keratosis, so it is somewhat related to the keratin which is released from the lining of the external auditory canal. Okay, so next question. Now identify the lesion of the vocal cord in a 2-year-old child. Now if you look at the image, you can see that this is some pathology here, right? So again you can see here it is affecting the vocal cord. So yes, any idea what is this? Now this is known as laryngeal papilloma, right? So laryngeal papilloma or papillomatosis, and again this is caused by human papilloma virus. Okay, so this is laryngeal papillomatosis, and this is a line diagram in which you can see that this is how it actually looks. So it is involving the margins of the vocal cord. Here it is in the anterior side, here it is in the middle, extending up to the posterior also. So this is all laryngeal papillomatosis. So just you can remember the image. So again in this you can see here this is all laryngeal papilloma. Okay, so laryngeal papilloma caused by human papilloma virus. Now this question is very basic and it has been repeated in other exams as well. So here a 4-year-old child has hoarseness of voice and sore throat, and clinical examination image is shown below. What can be the diagnosis here? Now hoarseness of voice, it means there is change in the quality of the voice, there is pain in the throat, and especially in a young child. And what we can see here, actually we can see membrane formation. So there is usually a grayish to yellowish membrane formation, right? So this is a membrane. So membrane in throat, and I think most of you must be knowing that whenever you have a clinical presentation of a child with the membrane in throat, the very first possibility which should come to your mind is of course the diphtheria. Clear? So of course there might be additional features like odynophagia, there might be neck nodes which results in bull's neck. Clear? So a classical case of diphtheria. Membrane in throat is very important clue here, and you can see there is a classical membrane in the posterior pharynx. So there are bull neck, which is enlargement of lymph nodes, right? And what we can see a pharyngeal membrane. Okay, so that is very important for making a diagnosis of diphtheria. Now then there was a question about the maneuver which has been showed into 5 stages, and what we can see here, the person is sitting on the couch and he had turned his neck to about 45 degrees, right? So 45 degree turning of neck, something like this. Okay, so while sitting, so you can say this is the left side of the patient, so he has turned his neck 45 degree, turning to left, right? So neck is turned 45 degree to left in first. In second, keeping the neck turned, now he lies down. So keeping the neck 45 degree turned, patient lies down. This is in the step 2. Now in the step 3, the patient will turn the neck to other side, again 45 degree. So this was left. Now the patient has turned the neck towards the right side and still lying down. So lying down rotates total of 90 degree, right? Because he has moved from this side, right? So initially he was here. So from here to here is all 90 degree. So this movement is total 90 degree. Clear? So the total movement is 90 degree. So this is total movement is 90 degree, and is, in simpler words, 45 degree to right side from center. Clear? So if I draw a center something like this, it has gone to 45 degree from the center. But if you count it from the position of the image number 2, it is almost 90 degree, right? So this, please mind these words, what actually is being given. So this is in third. Now what patient has done, he has turned the body into right lateral decubitus, right? So turning into right lateral decubitus. Clear? So you can see the body has been turned. And now what you can see in fifth, patient is sitting upright. Clear? So this is the sequence of movements which is done in a test, in a maneuver which is known as Epley's maneuver. Clear? So this is known as Epley's maneuver, and this is done for benign positional paroxysmal vertigo. Clear? So this is done for which condition? Benign paroxysmal positional vertigo. Okay, so this is the Epley's test. Now why we do actually this? Because in this condition, benign paroxysmal positional vertigo, there is formation of calcium crystals. Okay, and these are known as canaloliths. These are also known as canaloliths, and these canaloliths, they can come into the semicircular canal, right? So they can skip into the semicircular canal, and if they do so, this can result in vertigo. Clear? So this is the problem. So what we are actually doing in this maneuver, we are actually putting all these canaloliths back into the saccule, right? And this way we are minimizing the chances of vertigo. So this is the Epley's maneuver, which is done for benign paroxysmal positional vertigo. Fine. So this is important. So what we do, if the canaloliths are, say, somewhere here, right? So these are the canaloliths. We try to change the position of the semicircular canals by positioning the position of the head. We are just trying to move all these canal bags into the arterial, or like somewhere here. We just want to bring all those canalets into the arterial, right? So this way we are minimizing the possibility of the vertigo, right? So this is the concept of Epley's maneuver, which is done for benign paroxysmal positional vertigo. Clear? So please remember Epley's maneuver. Again, you can see in this image, the patient is sitting in step 1. He will turn the head to 45 degree towards the affected side. Then in the second, keeping the head turned 45 degree, he will lie down. In step 3, he is still lying, but he will turn the head towards opposite side 45 degree, or the total movement is 90 degree. And then in the step 4, he will take a lateral decubitus position on the same side, which is there in the step 3, and in the 5th step he will get up. Clear? So this is Epley's maneuver. Chalo, next question. A patient is having rhinosinusitis. Okay, and then the CT scan was done. Now, which sign is visible on this CT scan? Right? So if you look at this is all maxillary sinus. Okay, so this is all maxillary sinus. So if you look here, you can see two kind of shadows in the maxillary sinus, right? So you can see two kind of shadows in the maxillary sinus, and therefore this sign is known as double density sign. So quite easy to remember, double density sign. Clear? So you can see two type of impressions within the maxillary sinus. So this is double density sign. Again, you can see in this coronal CT scan better. This is 1, okay, and here if I just mark it, this is first type of impression, and this is the second kind of impression. So this is double density sign. So please remember double density sign, quite easy to appreciate on CT scan. Now this is again a very beautiful questions, and although very rarely asked. A child has frontal headache, fever and progressive swelling of the forehead. CT scan is also given. Now can you reach up to a diagnosis here? So there is headache, fever and swelling. I think all of you can mark out that this area it has swollen, right? So this is all swelling here, and this is seen somewhat related to the frontal bone. And now here, if you can see on the CT scan, this is a sagittal view, and in this area you can see there is swelling, okay, and this is a classical case of the Pott's puffy tumor. So this is known as Pott's puffy tumor. Now here there is frontal sinusitis, which leads to frontal bone osteomyelitis. Clear? And secondary to this, there is abscess formation and subperiosteal collection. So frontal sinusitis. Now this presents as office headache. This is also known as office headache. Why? Because it shows periodicity. And when we say periodicity, the pain will start at say 9 a.m., will peak at say around 1 p.m. and will disappear by 5 p.m., right? And this is the usual office timings. So the patient usually, if suppose he is working somewhere, the moment he enters into the office, he will say that I am having headache, which will peak somewhere by the lunch time and will disappear once he is about to leave the office. So the fellow colleagues will think that he is making excuses as he don't want to work, but this is not an excuse. He is having frontal sinusitis, and since this shows a characteristic time period based symptomatology, and which is more correlating with the office timings, so it is known as office headache, right? So this headache is actually, it must be a periodic headache, then it is very highly suggestive of frontal sinusitis. Of course, then fever suggests there may be abscess formation, and swelling is just documenting that there might be collection, and which is better visualized on the CT scan, right? So this is Pott's puffy tumor, and the word tumor is here, but please, this is a misnomer. It is not a tumor at all, right? So this is the Pott's puffy tumor, which is swelling of the forehead, which is because of osteomyelitis occurring because of frontal sinusitis, right? And that the swelling which is appearing in the forehead is actually subperiosteal pus collection. So it is the pus which is coming out because of frontal osteomyelitis. So this is a very interesting condition, that is Pott's puffy tumor. Clear? So this is the whole concept of this entity, Pott's puffy tumor. Now there was one question about surgical reconstruction or widening of the cartilaginous part of external auditory canal. Now what is the term given to this surgical procedure? Now we know that external auditory canal, which is about 24 millimeter long, it has two parts. The outer is cartilaginous and the inner is bony, right? So sometimes we try to widen this outer cartilaginous part by doing a surgical reconstruction, and this is known as Meatoplasty, right? So this is known as Meatoplasty. Now the word meato is again related to the external auditory meatus, and plasty means surgical reconstruction. So plasty is actually surgical reconstruction. Clear? So this is Meatoplasty. Fine. So this is, and if you can see here, these are the steps which are involved in Meatoplasty. So again you can see this was the original, and now it has been enlarged, something like this. So this is Meatoplasty. Chalo, next question. And here a clinical image of the oral cavity has been given, and the person is having fever and he is having odynophagia. So what can be your diagnosis here? Yes, anyone? What can be the diagnosis if you have a patient who had come to you with fever and odynophagia? Now the word odynophagia means painful swallowing or deglutition. Clear? So here actually if you look at the clinical image, now this is uvula. Okay, so this is uvula, and you can see here there is swelling here in the area of tonsil. So this is a case of peritonsillar abscess, right? So peritonsillar abscess, which is also known as quinsy. Okay, so this is a classical case of peritonsillar abscess, which is also known as quinsy. And here there is one more important symptom or feature, that is hot potato voice. So please just add this word as well, or you can say the muffled voice, right? So this is classical of peritonsillar abscess, which is also known as quinsy. And as far as the treatment is concerned, start IV antibiotics. Okay, then we can do incision and drainage, right? And third is interval tonsillectomy. Interval means there is some time period, so that is around 4 to 6 weeks after the attack of tonsillitis. So you need not hurry up. You can wait for 4 to 6 weeks after this onset, and therefore we call it interval tonsillectomy, right? And here also there is one important principle in incision and drainage, because whenever we are discussing the principle of surgical drainage, incision and drainage for pus, we always say that the incision has to be given on the most dependent part of the collection, right? Because that will aid in gravity aided drainage. But here that rule is not followed. We give the incision somewhere on the non-dependent portion, right? So non-dependent part. So that is one important surgical fact which is not followed here, right? So incision, if I write about incision and drainage, usually dependent position, clear? And this will gravity aided drainage. But in quinsy, non-dependent upper portion, clear? So that is very unique about this quinsy. Fine. So this we have already discussed. Now I think most of you must be knowing what is being shown in this image. So a person is having road traffic accident, and then he developed with post-auricular hemorrhage, right? So this is all post-auricular hemorrhage, and this is known as classical battle sign. So here this is the area of mastoid process. Okay, so this is all mastoid area. So this is the battle's sign, and I think most of you must be knowing what battle sign is. It is fracture base of skull, especially middle cranial fossa. So this is the battle sign, right? And most of you must have heard of raccoon eyes, which is in anterior cranial fossa, both involving the skull base fracture. Okay, so this is the battle's sign, which involves the base of skull fracture, especially involving the middle cranial fossa. Now this is one question, and again I have repeated it with options, and let me see you whether you can answer it or not. This is about the tubercular otitis media and all except. So you have to mark out the wrong option. Yes, anyone who can answer this particular question, we have already discussed it in that image based question, and I think most of you must be able to answer it. Let me see. So which option is not the right option for this particular question? Yes, anyone? Which of the following is not a feature of tubercular otitis media? I think it's not that tough. Yes, you can try answering. Moreover, there is no punishment for wrong answer, so please feel free to answer it. There are two important points which I told you about tubercular otitis media. Number one is painless watery discharge, right? So the very first which I told you was painless, and if you look in this MCQ, the very first option is painful, so that becomes the answer automatically. Apart from that, multiple perforation is very classic, pale granulation tissue is classic, and the discharge can be foul spelling, that doesn't make any difference. So this is absolutely wrong for tubercular otitis media. Okay, and this is again, you can see one perforation here. This is one perforation, this is another perforation, and then you can see this is all granulation. Clear? This is all granulation and these are perforation, right? So these are perforation, and then you can see the pale granulation, classical otoscopic finding of tubercular otitis media. Okay, so this is the tubercular otitis media. Fine. Chalo. Next question. Occipitomental X-ray of paranasal sinus. Now, occipitomental X-ray of paranasal sinus. There are two classes: closed mouth or open mouth. Right? So this is known as Waters view, and this is known as Pierre's view. Right? So the term is different, although the alignment of the skull is same. So if the mouth is closed, that is Waters view. If the mouth is open, it is known as Pierre's view. And the purpose of doing and the sinus which is best visualized on closed mouth is maxillary sinus, although we can see many structures, but this is best visualized. And Pierre's view is for visualizing the sphenoid sinus. Clear? So the best visualized, you can see. Clear? So this is the basic difference of this occipito. So here you can see this is the Pierre's view, and the mouth is open, right? So this is the open mouth view, right? And this is the orientation of the skull, so that is known as occipitomental view. So this is the occipit, and this is the mentum, that is the chin, right? So Waters view if the mouth is closed, and Pierre's view if the mouth is open, the alignment of the skull remains the same. Now next question was about partial closure of nasal orifice is done while treating which condition. So nasal orifice or nasal openings, they are either totally closed or partially closed. This one is actually modified Young's operation. Clear? If we totally close it, that is the Young operation. This is modified Young operation, and this is done for atrophic rhinitis. Okay, so this is atrophic rhinitis, and this is how we do modified Young operation. You can see some opening is left behind, whereas in classical Young we are obliterating the nasal opening closely, fully, completely. So classical and modified. So partial is modified, right? So this is the partial closure. This is complete closure, right? So very basic. Now this is one question which has been repeated in FMG as well. So if there is stimulation of external auditory canal, patient starts coughing. Now which nerve is stimulated? So maybe some procedure was being done on external ear in the external auditory canal, and patient started coughing. Now this is because of one nerve which carries the sensory innervation from the external auditory canal area, and this is actually the auricular branch of vagus nerve, right? So this is the area, this is the territory which of auricular branch of vagus nerve. So if there is any irritation here, that might lead to coughing. So this is auricular branch of vagus, right? So this is auricular branch of vagus. In the red you can see this is auriculotemporal nerve, which is from fifth nerve, right? And then lower down you can see this is the great auricular nerve, right? So which supplies the lobe and the angle of the mandible as well. So if this is irritated, this will result in coughing act, reflex coughing, right? So this is auricular branch of vagus nerve. Now next question, again this is a surgical question actually, slightly difficult. And which of the following is not a landmark for facial nerve identification during parotid surgery? Now we know that the facial nerve, it passes through the substance of the parotid gland. So whenever we are operating on parotid gland, we have to be very vigilant. We have to dissect out the facial nerve properly so that it is not injured, right? So now what are the surgical landmarks which actually tells us that we are somewhere in the vicinity of the facial nerve? So what are those landmarks? And this question is about all except. So which is not the landmark related to the course of facial nerve whenever we are operating in the area of parotid gland? Yes, any idea? Anyone who can answer this question? Yes, slightly difficult, I do agree. But see, digastric muscle, it has got two bellies. Posterior belly is supplied by facial nerve, and the anterior belly, it is supplied by the glossopharyngeal nerve, right? So that way you can also think of answering this one. But again, the better way is to know the exact anatomy. So tragal pointer, posterior belly of digastric, and of course the branches help us to dissect out the facial nerve. So of course the answer is anterior belly of digastric here. Now let us see in the image that what are those areas actually which help us to identify the facial nerve. So firstly we will mark out the facial nerve in this image. So this is the facial nerve, okay? So this one is the facial nerve. Behind the facial nerve, this is all mastoid process, okay? So this is all the area of mastoid process, right? Then in the background of the facial nerve, you can see one bony process, and this is known as the styloid process, okay? So this one is the styloid process here, okay? So this is the styloid process. Then lower down you can see one muscle, and this muscle is actually the posterior belly of digastric muscle. So this is the posterior belly of digastric, okay? So this is digastric muscle, posterior belly. Now above the facial nerve you can see one cartilaginous pointer, that is the tragal pointer. So this is the cartilaginous pointer, and that is actually related to the cartilage of the external auditory canal. Okay, so this is the tragal pointer, right? So what landmarks you have to remember? Number one is the posterior belly of digastric. Number two is the tragal pointer, and third, the branches of the facial nerve, because when it travels through the substance of the parotid gland, and then it divides into its 5 branches, right? So it divides into its 5 branches, something like this. Okay, these are all 5 branches of facial nerve, right? So we can just, we can trace the branches to reach up to the main parent facial nerve. So we can also go this way, and we can reach up to the facial nerve, right? So these are the branches of facial nerve, right? So these are 3 important structures which help us in surgically marking out the course of facial nerve, right? So again, on the right side in the image, you can see this one is the facial nerve. Okay, and then this is the territory of the marking of the mastoid process. So this one is the mastoid process. Okay, lower down you can see the posterior belly of digastric muscle. This is the posterior belly of digastric muscle, right? And then upper side you can see this is all external acoustic meters, and there may be a cartilaginous extension which is known as the tragal pointer. So this is the tragal pointer, right? And again, if you see in the dissected portion, this is the outline of mastoid. Okay, this is the posterior belly of digastric. Then this is the external auditory canal. Okay. And then here this is all mandible. Okay, so this is mandible, and then here we can see the facial nerve. So this is the facial nerve here. Clear? Something like this. So this is the muscle, digastric muscle. This is mastoid process. This is external auditory canal. This is the facial nerve. Okay, so this is how you can understand, right? So this is how these are the surgical landmarks which actually help us in locating the course or locating the facial nerve or its branches, right? So this is very important if we are operating somewhere around the area of parotid gland. Okay, so that's enough for this session, and thank you very much for joining me so late in the night, and I'll try to come up with something more because we have a couple of days with us. So either we can go for revision classes, or I'll try to take a few more subjects. So let's see how it goes. Anyway, thanks for sparing your valuable time. Stay blessed. Good night.